and everything like that, he's going to be roaming the room. So I think that'll help to make things, excuse me, a little more interactive. And I think that's going to be a big goal for today, is that we want all of you to be able to participate, ask questions, and contribute as we go. Thank you.
Thanks very much for that kind introduction. I appreciate very much the opportunity to speak with you all. And I know that there's a few of you who were not present for this week's activities, so you could refer to your program. There was an awful lot of very interesting stuff this week. I actually suggest you cut these out and make trading cards out of them. My trading card won't be worth a lot, but the Genevieve Morris card, be sure and keep the Genevieve Morris card close to your heart, because Genevieve told us, and she's the new deputy ONC director, that was telling us an awful lot about how she felt the current state of the market looked, and what she felt like needed to happen. One of the big things she highlighted that we need to go figure out is a trust framework. It's one of the things that they're doing. The ONC is also writing herd over an activity related to health directories that we also heard from another gentleman who is another important trading card you want to keep track of. I've lost your trading card. Oh, I can't. It's terrible. Remind me your name. RIM. I was thinking, I knew it was a three-letter word that I didn't. I was thinking that it related in some way to the standard. But in any case, the other really interesting person that I felt like had a lot to offer was Julia Adler-Milstein, who I think highlighted some of the high-level issues that we see in terms of barriers. She highlighted barriers that I hadn't maybe articulated prior. One of those is really related to how do patients feel about this anyway? You know, do patients really want to have their data shared? It's an important topic. So anyway, very interesting week. Learned an awful lot about the barriers, certainly to healthcare exchange. We learned about the status. I think what I want to try and, have a clicker up here, or will you guys just move the thing along when I say boop? That will work too. So I heard a great phrase this week: patience and impatience need to be balanced as we consider this. I mean, frankly, people are pretty impatient about this whole exercise. The thing I would invite you to remember about healthcare IT, thank you so much. Okay. So what I would like you to do is to think about the fact that healthcare isn't like the banks. So the banks got together and figured out how they were going to exchange, make it so that you and I can get a $20 bill where we go anywhere in the world. That's cool. Banks had been automated for 25 years. I mean, so this is a big difference. So healthcare, you know, got automated just recently. It's the last, somebody called it the last cottage industry. You know, it's like, so to expect, it's actually more like the grocery stores. It's amazing how fast the grocery stores went from being like unautomated to like being able to do everything, you know, with a scanner. So I think we have to be somewhat patient. And so the question of, you know, give me the next slide if you don't mind. It's the question of whether we're there yet. You know, I don't think we're there yet. We have. Sorry? Oh, okay, thanks. So the question of whether we're there yet, I think, is important to consider. It depends on where there is. This is another thing Julia said I think that was very useful. What is it we're trying to do? You know, I mean, if what you're trying to solve for, and you can declare victory only if you set yourself an endpoint, you know, so it's, I think the idea of using use cases, this is sort of a my hand thought. So if you go to your trading cards and look at Tim Pletcher's card, I mean, Tim last evening did a really good job of describing how MyHand is approaching this problem. I think very interesting approach, which is to basically Not look for a single tool that solves all the problems. That's a jackknife that I can, that's missing a spoon, and I got to go buy a spoon later. Like I'm not going to buy one tool and everything. I'm going to think about this from the standpoint of a use case. I'm going to solve that use case, and I do so modularly so that I can, I can go do things as I need to solve them, and I can use those modules for other use cases as they come up. So I think that's a pretty interesting thing. That kind of infrastructure is needed in order to make this stuff all work. But the fact is, it isn't present, and it's different in different states. And Michigan may be a good model, but the fact that it's different in different states makes it very difficult to do this across state borders. So are we there yet? We're really, really early, actually, in a lot of ways. Query-based exchange, which is one use case of these many, many use cases we need to work on, has advanced a ton in the last 2 years. But that is not the thing that everything needs, right? I mean, some things require supporting a volitional act. I want to refer to you. I want to send this data to them. That's a push, and that's not a query, right? So query is not, won't solve everything. It solves a lot, but it doesn't solve everything. And there's, other, I need to aggregate data sometimes. There's like some of the data I need to aggregate. So there's lots of different use cases. So if you give me the next slide, I want to share with you just a little bit more thinking about what I think is needed in healthcare IT and how it relates to what I think is the analogous problem, which is the internet. I mean, we're trying to build a network, okay? And it's not the same as the internet. It has different requirements, for one thing, but what's the same about this from the internet is that the internet is an arbitrarily large number of endpoints that wants to be reached by an arbitrarily large number of users. It's the same problem. And so would the internet work if I had to wait for web pages to be sent to me? I mean, that is what the USPS was. That's what the Postal Service used to do. They used to send, so I would call up and say, I'd like some product information about such and such, and they would mail me product information. That's old school, boys and girls. That's healthcare. I mean, healthcare today is, can you tell me about the patient? Fax it over. That's the way it works today. The problem with trying to replace that is that is actually really easy to do. It requires some orchestration, but it's not a ton of work to make a phone call. Although if I have to make 25 phone calls a day or 50 or 100, it's untenable and it costs a lot. So if I reduce those costs, and it drives a change that could really, really make a difference in healthcare in terms of costs, in terms of efficiencies. But it's a hard problem to make arbitrarily large numbers of endpoints lit up. So the other problem is at the beginning of these kinds of things, you run into it's a cross-rough between competition, because everybody's trying to do different things and they're trying to make them better and better, and the fact that different technologies behave differently, okay? So competitive technologies are based on standards, and standards writ large, include things like, the browsers. The browsers, based on the notion I can deal with HTML. So browsers, if you recall, so some of you are too young to remember, but websites didn't all work the same. It depends on what browser you're using. Radical differences. Rendered it totally differently. Some just times failed. It was a real problem. And it was and it's still a problem, but it's very, very much smaller problem. So during this period of time, literally, the behavior of the different vendors in the browser space was predatory. They're like, let's make it do this so that theirs won't. And when we go to this website, it was like that. That's the way things were. And it took a long time to shake that out. I mean, so this is, 1995, that was the beginning of that exercise. I mean, the internet was around a long time, right? I mean, you could argue we have the internet of healthcare already, but we don't have the web of healthcare, okay? So go to the next click. So there's still a worldwide race related to desktop, but if I asked you, which one of these you use and what websites don't work, what you'll tell me is that generally they all work. They do have different bells and whistles, but for the most part, there's less, but this took a long time. So between 1995 and 2016, we're talking 20 years. So next slide. So the other thing is, this is growing incredibly fast. The internet started to grow really when the browser began. So once you had browser and Google, then the internet grew. The internet didn't grow as long as I had to type in an IP address, because that was the way it was in 1977 when I graduated from high school. To get a book from the New York Public Library, I have to telnet to the New York Public Library, log in and search for the title, and then call the local librarian who will call the librarian in New York and have it sent to me in a brown paper bag. That's, if it's nasty stuff, I guess, if it's brown paper. So those 50 billion internet nodes predicted by 2020, it was really not that long ago that we crossed 1 billion, right? And so the difference here for healthcare over internet is that it took 20 years for the internet to go from connectable to discoverable and like ubiquitous. And that was with a ton of business reasons to do it. In healthcare IT and interoperability, the business case for interoperability nationwide is not there. I mean, people are not motivated to have their data shared. They're not even sure they want to share their data. So it's fair that it's taken a while because the motivations are lacking and we have a lot of hard infrastructure to build. Next slide. So let's just do a quick compare to healthcare IT and the internet. And I'm not going to spend more than 5 minutes on this. So actually build this all out because otherwise we'll have to do boop, 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 which will drive me crazy. So the difference between powering the World Wide Web and powering healthcare internet. So if you think about how this started in the 60s, and I started my life in healthcare IT in 1993, or actually 91 if you count my early work. That was arguably the beginning of what I would call the clinical data repository era. It's like the very, very beginning of the notion of a clinical data repository. And those clinical data repository companies became portals and then became HIEs for the most part. So that line at about middle 90s sort of builds on what came before on both sides. So up top, computers and networks and the internet and the inventions that supported, the possibility existed before 1990. But it was 95 when infrastructure became available, when actual infrastructure to enable, that was shared infrastructure, what Mahan likes to call shared services. Shared services enable the kinds of things that we want to get done in healthcare IT today. And without those shared services, the stuff just doesn't work. It doesn't scale. So you got browsers, you got central DNS management, that DNS domain naming service. That's why you don't have to type out the IP address. It's because it knows now that infrastructure, those domain naming servers that are all out there, they're put up by all sorts of different people. That environment is managed by central management, but it's not, all those servers are not owned by one entity. It's like a huge decentralized model. Okay, so the internet is, so really go ahead and build the rest out. So to get to what we need, in the clinical data repository portal HIE realm, everything was around a single jackknife. Got a tool, here's my tool, everybody goes through that tool. You want to get to me, go through the tool, get to him, go through that tool. Okay, and I thought we were going to have 50 of those tools. Well, no, we got like 90, or I don't know how what it is. There's just jillions of these HIEs. And so making them all interoperate, a really hard problem. So, so you had the notion of some national exercises that began about 2010. So with the National Health Information Network, that was a government exercise that then became the Sequoia Project over time. And then the big change, the big mover, was meaningful use. So once meaningful use came along, the portals made a choice. They're like, okay, I'm not an EHR because I don't do orders, so I'm done doing that. I'm going to be something else. I'm going to be an HIE, or I'm going to be a population health platform. So they made their moves. And then Commonwealth came around, and Commonwealth was the first actual infrastructure to be deployed on a nationwide basis. It's a very small piece of infrastructure that we need. I mean, it's only one piece of infrastructure, which is enabling this notion of the patient is in front of me, where are their records nationwide. Okay, that's useful, but it's not the only use case. Also, you have other ways of doing this. So you got directed query, which is how care quality wants to work. So when Commonwealth and care quality made an agreement, they're agreeing to allow for data exchange on the lowest common denominator, which is to say, okay, I'll do directed query between these two environments too. So that will make it, I think, a lot of endpoints are connected. So next slide. But, so there's a lot of road. We put a lot of interstates up. You know, how good would the interstates be without city streets and without driveways? You know, not very, very good. So the problem right now, we have a lot of road laid. There's a ton of infrastructure around how this stuff is going. But there are still not a lot of driveways, which is the on-ramps, right? I don't have the on-ramps because, like, not everybody's participating. And worse than that, there are no trucks on the road. They're like Yugos on the road, like driving around. And Yugos is a good choice because they're really not really good cars either. So the data we have available on the road is not really great yet. But can't blame the road for the traffic, okay? It's not the road's fault. It's the endpoints, okay? So nobody bought anything better than Yugo, and nobody put it on the road. Next slide. So there's also gaps, right? So that Commonwealth care quality thing, you got to get from 70 to 90% of acute, there were a couple outliers, and those outliers, you need to create a bridge. And so that bridge is a big piece of work, by the way. So this is not a simple exercise. So I just want to make clear, our hope is that happens next year. I think I'm remaining hopeful, let's put it that way. But it's big work. It's a heavy lift. Next slide. Okay, so now here's the thing. I said at the beginning that we're talking about something that is an arbitrarily large number of endpoints and an arbitrarily large number of users, right? So people who want data and people who have data, and then connecting those people. How do I do that? In a way that is like the internet, in that I didn't have to pay anything extra when Amazon.com's website came up, right? Nothing changed. It was a true network. When Amazon lit up, I can get to Amazon the same way I got to whatever website I was going to before Amazon lit up. All right, it was exactly the same. Didn't have to change anything about my workflow, but I immediately have access to Amazon data. That's going to be the requirement. So I found this guy. I've never met him. I just was Googling and found, I was Googling some stuff around the hard problems. Because the hard problems are the organizations who don't have any money. Because we said one of the big barriers is cost, and I stated, in a, I don't know, maybe somewhat rude comment that I made is like, same is big. Like if everything is the same, it's cheaper. But it's different, it's costly. And so if I'm going to do these hard cases, and the margins in these businesses are so thin that their ability to pay, $25,000 for an interface is just a non-starter. They just can't do that. So this guy, go ahead and flip to the next one. I found this a really interesting article because, he's of course specifically talking about long-term care. He's talking about the post-acute space. But he's saying the things that we all know are the issues. First off, provider organizations are market rivals, and they don't want to share data because they think data is an asset. And that has remained a problem. It is not yet fixed. They may have more to lose than gain by data sharing. This is a relatively recent article. And I spent the last 3 years trying to cajole Cerner clients into the idea of participating in the Commonwealth exercise. I can tell you that their understanding or their willingness to share data isn't universal. I mean, some are more interested than others. Interesting, I took issue a bit with Ms. Milstein's, and she's hyphenated, I can't remember the first part, but her characterization of the hardest case. My personal experience is that the nearly hegemonous local IDN is the hardest case because they think they bought everything they care about. They won't want it. They don't want to exchange anything. They've got a new, bigger silo, the ACO. This is, now I got my data, I'm not going to share with anybody, and I'm not interested in data outside that because healthcare is local. If I had a nickel for every time I heard that said, that is just garbage. Healthcare is not local because I'm not local. I'm here today. If I get sick on the way, I'm going to be in one of y'all's hospitals. So, I mean, I don't buy healthcare being local. Okay, so who should pay? I mean, the models that are out there today, most of the models that assumed that one player would pay failed. The best model will be one where everyone pays something, because this is something else I heard from Genevieve, and this was not something she said from the stage. Zero is not the right price to pay. It's not fair to pay nothing. I mean, paying nothing for the internet is fair, but paying, you wouldn't want, it's not reasonable to ask for free internet service provider access. That's not fair. So to me, these are the analogous things, right? So an interface is really an ISP. If it got me everything, it would be, right? That would be great. Would I pay something to have an interface? Yes, as long as I could afford it, and as long as it got me everything, and I wasn't connecting to some jackknife that was missing 4 of the tools I needed, okay? And this low margin problem is huge. So next slide. So here's another big problem, a hard problem, and this is just meant to represent the general notion that it's not only a hard problem, it's one of the more important problems. I mean, behavioral health data, there's good indications today that, managing chronic illness that has mental health or substance abuse as a comorbidity makes it like 5 or 10 times as much money to take care of that patient. So managing their behavioral health is really important, and yet the data about behavioral health is hardly being shared at all, because there was a big move this last year where, and we heard about it this week from one of the speakers about how the SAMHSA regulations have opened up a bit and allowed general consent to support the exchange of healthcare data. Oh, except for SAMHSA data, which is to say 42 CFR substance abuse related data. That data is still subject to different rules. Now, it's still, I can do a general consent, but there's a rule still that's present that's a little scary, which is the person who discloses the data initially has to tell to whom they're disclosing that they have an obligation not to redisclose. This remains in the law. And none of the technologies that we have support that capability. As a consequence, no one who's read the reg and knows what their problems are is going to share under this model. Despite the fact that they feel like they've opened the door and everything's going to start sharing, no one will share under this model. Because people, it's not the law, it's the lawyers. I mean, people can still sue when data is redisclosed from a secondary location, and they get to sue the initial discloser. And so, as an initial disclosure, I'm not going to do that. So, Another hard problem. How do we solve that? Well, do we need a nationwide consent service? Good question. Next slide. All right, here's one I learned about that I think is really interesting. So this is a terrible market. I mean, there are companies that serve it. I mean, and they're making some money on it, but the margins are really skinny. This is the school nurse EHR business. Okay, it's a really pretty small. There's like 4 players in it. I talked with one of them who has 10,000 nodes. Okay, and the really amazing thing is when I talked to the woman about this and asked her, well, so how many patients do they see a day? She said, oh, it must be like 20. It's like, no, it's like average is like 140. It's like they see 140 a day. Now, they may not be communicating on 140, but they're communicating on probably 50, that's a lot of data. But the amount of money that they pay for their software is very, very, very low because they don't have any money. There's a very small amount of money and dwindling amount of money for ancillary services in schools, right? I mean, so school nurses, you know what the average number of students to school nurses is? It's apparently 4,000. Like, that's just unheard of. And the really amazing thing is that those nurses are frequently the only health care the Medicaid recipient child gets. I mean, particularly if they're moderately well managed diabetic. This may be their care manager. And the data there is a complete silo. They collect it, but is made available to no one outside the healthcare system unless they fax it. Or they're gradually, I think they're moving toward direct messaging, be able to get direct messaging sent to the PCP or whatever. Here's something you need to know about this child who showed up in my office and has these issues. This is a really hard problem. So this is a part of the arbitrarily large number of endpoints. Because if you're going to solve healthcare, even one use case, because this is just the same, let's just consider query. Can we make this queryable? Well, never mind the other things. If we're going to make it queryable, it's going to have to be cheap. Really cheap. Free, no, but really cheap. Okay, next slide. We can skip over this because I'm running a little out of time. I think I have one more slide. Yeah. So what do we do now? So the focus for today is meant to be a workshop around what it is that systems need to provide today. To my way of thinking, I've simplified this in conversations with C-suite folks who need the simplest possible explanation for everything. Really, we're talking plumbing and fixture here. So the plumbing, the set of infrastructure that enables exchange, I would argue is not, there isn't one tool that fits everything. There are use cases that you need to manage. Each of those use cases you have to work up separately, and you have to understand the requirements and what tools are best to provide. So that infrastructure stuff is getting built. In a place like Michigan, lots of modules have been built, solving things like health directory, solving problems like actually a universal model, an all-payer model around having pushed from where it is to where it needs to go. I mean, really interesting stuff that's been done here. That infrastructure is all plumbing. And one of the things that I said maybe also rudely yesterday was, or day before yesterday, was that it is unreasonable to assume that the data that flows on these highways gets much better. The data will continue to be bad for some time, and it will be variable forever. It will vary as one system gets more capabilities than the other, and practice will change, like just what happens inside of a health system, their practice impacts what data shows up. Like how I go about registering a patient, I was skeptical of the notion that I think it may have been Ms. Milstein, it may have been Genevieve who mentioned that there is a goal, I think it's actually Genevieve, there's a goal to go back and educate. I think they called it I can't remember what they called it. It's basically a guideline for how to register patients. And what I can tell you is that from experience, working with registration clerks, the chances for us to tell everyone in the nation to do the same thing and when they register, it's just not reasonable. It's not going to happen. It'll get better, but like, do I use a hyphen in a hyphenated name or not? Do I use, all those kinds of things, those impact our ability to do patient matching. Identity remains one of the biggest problems. That's what Common Law wants to solve, is identity. I'm not here to say I think Common Law has totally solved identity, but it is at least a shared service that runs across state lines that does manage identity. So this is the big problem that affects not the plumbing, but the fixtures. So the big problem that I think the vendors need to then focus on is, right now everybody's complaining, there are no cars on the road. Well, the next problem is traffic jam. I mean, we're going to have a crap load of data being exchanged. And a lot of that has to do with the fact that the standards aren't. So what is available today is the summary of care. And so what a lot of folks are doing, Cerner clients I know are doing it. I know I overheard you talk about Trinity. So a lot of the documents that they're sharing are CDA wrap PDFs that represent the other documents that are available beyond the summary of care. Valuable information, really important to be shared. But you got to be careful how much you share. You're going to be like, I don't want to go to them because every time I go to them, I got 12 documents per encounter. And the applications that deal with those 12 documents per encounter, initially they're going to have problems because they're just list metaphors for the most part. If you know what I mean, they're just like, okay, here's the list of documents available. Which one would you like to look at? And that's, so I think that the vendors all have a responsibility to build out capabilities, and actually they don't have responsibility, they have plenty of motivation because they want their users to appreciate these workflows. So I don't think it's, we can wag our fingers at the vendors if we want. I was one for a long time. I've had my face with a finger in it so many times I can't tell you. But the fact is there's plenty of motivation because the community of users are going to want new workflows. And so the workflows will need to be able to handle a number of things. They're going to be able to deal with acquiring the data and putting it away in a way that makes sense, that manages provenance. So, provenance, that's where the heck did this come from? Like they want to know, that the data, came from this place, is disclosed by this place. So that if there's a breach, they can say, by the way, a CCDA you sent me was in a tranche of stuff that was stolen. Like that they got to know that. They are very uncomfortable receiving data that they don't know where it came from and that they can't audit where it came from. They got to be able to do deduplication, which is a really, really hard problem, of individual elements. They also need to manage these long lists in ways that make sense. So in other words, can I collapse them up into a single list by organization so I can see, okay, they sent me a bunch, but I'm never interested in anything they send me anyway, so I'm going to collapse it all. I mean, those kinds of capabilities are going to be required in the user interface. And the user interface, someone used to work at Cerner a long time ago who, I don't know where he is now even, he used to say, a luxury once experienced becomes a necessity. And yeah, so that is absolutely true. So what's going to happen is once you have problems, allergies, medications, and immunizations that you can put away, they're like, how about lab values, please? I'm ready for lab values. When do I get lab values? Because that's really important to me. I don't really care about these other 4 things, which of course they do, but they only care about the lab because they saw how cool it was to get the problems. But now they're like, the other phrase I heard from an IDN's CMO was, nice as far as it goes. Okay, so that's the thing. I think what I would say to you, I would submit to you where we are today. Are we there yet? Well, it's nice as far as it goes. And we've got a long way to go, but what we've got is actually pretty exciting. So we've got huge movement. We've got potential change in the structure of our incentives. We've got, which is going to probably have the biggest difference. So once it is no longer a disincentive to get data on a patient in the ED, I mean, this is another maybe rude thing I said. I'm not saying that the doctor at the bedside would ever not want all the data that he or she has access to. They would. But does the CEO of a small health system, and I've seen the CEO of a small hospital in flu season, they are all smiles. I mean, for reasons you can understand. I mean, flu season is their banner time under fee-for-service. And until fee-for-service shifts, they still smile in flu season. I mean, so once we get to the motives being, switched here, where really having all the data, I'm responsible for the patient when they leave my environment, when there's leakage. In a lot of cities where, or states, in California in particular, Kaiser repatriates patients, as do a few other organizations. When they're managing, a capitated model, if a patient shows up across town and it's safe, they will literally move them. They'll put them in transport, take them over to the other place, because they're at risk for all that care, and they want to make sure that they do the right thing. Now, if the patient leaves California, goes to some place where Kaiser has no footprint, they value getting that data because they're under a full capitation model. And so these models are going to change people's interest in the data. It's going to really change motivation. Where today, people are insistent on this notion that healthcare is local, and that they can control their assets. And once we get to the point where we're getting paid a different way, they will want their assets available to everyone else when they're taking care of a patient for whom they have risk. So it's going to change everything. So that's kind of what I wanted to say. I know that, and I am really sorry that I'm going to miss the conversation that ensues because I have to go to a wedding. So I'm going to have to go run across the country and get on a plane and head back to Kansas City. But I know that you have, both Cerner and Epic representatives here to kind of talk through what it is they're doing. I, at this point in time, represent myself. I'm an independent contractor since the first of the year, so I'm not a Cerner associate. So I don't speak for them. But I speak for myself in saying I think this conversation this week has been really exciting. I think MyHIN has some tremendous ideas about how this can all be solved. They aren't all leverageable everywhere, but a lot of them are. So I'm incredibly excited about the potential of MyHIN. MyHIN happens to be a Commonwealth member, and I'm excited about the opportunity to work with MyHIN to help them figure out how to make the most of that Commonwealth connection. But that's one use case at this point in time. Commonwealth really supports query-based exchange today. Expanding the nationwide breadth of what it is we can do will require shared services nationwide in order to make them happen. Thanks very much for your time.
We could probably take a couple questions.
Oh, sure, absolutely. I think we need, if they want to have a Or you could speak into my chest.
I can do it.
Here he's coming.
Scott, great presentation. I mean, a great overview of all the progress that internet made versus what the healthcare. And I think that one of the points I want to ask you is the big improvement in the internet side was the DNS that you mentioned that created all this unique. And I think we're dealing in healthcare with the same biggest problem is matching the patient's unique ID. And I know that MyHand and probably Commonwealth is working on a common service key solution, but I think it's philosophically is wrong because it's again leaving the patient outside this all identity business. Nobody mentioned during the 3 days about the technology that I think that may possibly solve this problem, and I'm talking about the Bitcoin. I'm talking about this kind of approach when the patient will have a really control of all this identity. So can you talk about a little bit about this?
So it's really an interesting question. So first on the identity question in general, there's lots of different approaches to managing identity. They're generally regional. Commonwealth is the only national identity service that exists today. It is an identity service. It's actually pretty similar to MyHand's model. Exploring mechanisms that we can use to couple those so that they can leverage each other, it is something worth doing. But as far as using blockchain, which is the generic versus Bitcoin, I have heard it suggested that that would solve everything. At some level, though, the problem we have in healthcare in general is that there's a lot of legacy that we're pulling behind the train here. And so the comments I've heard from people said, if we'd started today and we were building something from scratch, would we use blockchain? We might. But the problem is that we have, and the need to have all this stuff built into the EHRs it's absolutely essential that it's built into the EHR. So if it's possible to create some sort of a bushing that makes it so that the EHRs don't have to change everything they do in order to participate in a blockchain, I'm a believer. I'm not a believer if you insist on the EHRs all having to do the same thing to solve the problem. That is pretty hard. I mean, the only way you get that done is with a regulatory hammer, and that has worked. I mean, we've gotten a lot of the same work done with the regulatory hammers, but we haven't. I think that would be a big lift to get all the EHRs to support that. Now, again, if it could be done as a sort of a bushing, it's believable to me, but I can't wrap my head around how that works. So someone smarter than me might, but so far nobody's been able to explain to me how it would work. I get the point, and I think it has value, particularly around that provenance question. When data goes from and is redisclosed, could I then literally manage the access to that data? That is one use case that is the hard one, like the behavioral health problem, and trying to solve, putting everything in a lockbox, I'm not sure solves our problem. Now, if we could even segment the data successfully, and then only put the lockbox around the stuff that has to have it locked, that would be great. But we can't even segment the data yet. Are you with me? So we're really early in the effort to actually make behavioral health data liquid, I think.